Mhm. Dear colleague, thank you very much. I would like to thanks the directors for this kind invitation. Uh, I have nothing to disclose for this presentation. I think I don't have to explain you the global burden represented by diabetic foot and worldwide, and you know that this is a global challenge in every health system that represent a very important uh, ambient for patient with the diabetic foot. Um, you know that not always is possible to achieve a satisfied revascularization in our patients. 70% of our patient has some degree of critical limb ischemia. 60% of our patient has acute infection. So in this patient, we need to perform n- revascularization as a tool for obtain limb salvage. In this paper that we published in 2019, we evaluate 1,024 patients treated in three consecutive patients from 2014 to 2016, 17, and we evaluated the percentage of patients with critical limb ischemia no option as 8.2%. And in this population, the 1 year amputation-free survival was 34%. So if we evaluate our capacity to avoid amputation in the global diabetic foot population that is higher than 95%, you understand that patient with critical limb ischemia, no option critical limb ischemia, is at high risk for major amputation. So we have decided to evaluate a different subset of patients with no option critical limb ischemia, and believe me, if you have a patient with critical limb ischemia without any possibility for revascularization and acute infection, the only thing that you have to do is a major amputation. But if you have a stable disease with rest pain, but without a progression of the local wounds, without any progression of infection, you can try to perform a conservative treatment. Uh, the surgical approach for diabetic foot is dramatically changed in the last 20 years. And now we are able to be to perform a more conservative, less ablative surgical approach. The probably the main ingredient of the recipe is to organize a dedicated setting for diabetic foot patients. So this is the example of of our hospital. We have a department dedicated for diabetic foot limb salvage. And in the last 5 years, 10 years, we have new tools that we can use in our operating room just for avoid major amputation in also in patients with no option critical limb ischemia. But in the last 10 years, probably there are new tools that we can use to trying to avoid amputation in patient with a critical limb ischemia without any possibility for revascularization. There are three different approach with the so-called regenerative surgery. The mechanism of the activity of these procedures are all the same. Mobilization of angiogenic factors from different localization, from peripheral blood, from bone marrow, and from the adipose tissues. Uh, the the use of mesenchymal and peripheral blood monocyte cells allows to shift the M1 to M2 macrophage population, increase the angiogenetic and the control of stem cells. You can see here there are many papers that allow how monocytes can able to orchestrate an angiogenetic procedure in patient with peripheral vascular disease. And probably one of the mechanisms of the activity of the peripheral monocyte cells is the producing of exosome, extracellular vesicles that are able to increase not only the new vascular supply in the lower limb, but also to increase and improve the amputation and amputation-free survival in this population. This is a patient treated with a CLI no option with monocytes. Is a local injection, two or three different application in a couple of 2 months. The second procedure is the use of transverse tibial transport. And the first evaluation started 20 years ago by Russian and Chinese colleagues that demonstrate that using this mobilization of angiogenetic factors from the bone marrow was able to increase the distal revascularization and increase the wound healing rate in diabetic patients. And this is another paper that demonstrated the use of transvestibular transport that was able to have an increased blood flow and the blood volume in the 3 months postoperatively. There is now some meta-analysis that demonstrate that in a population of more than 1,000 diabetic patients with diabetic foot, the use of tibial transport was able to increase the healing rate and vascular endothelial growth factor, ABI scores, and the VAS scores in limb salvage. The third and last procedure that we use in our daily practice in patients with CLI no option is the use of microfractured adipose tissue that we take from the superficial abdominal fat. And in this case, also we are able to increase through the exosomes vesicles all the angiogenic factors that are able to increase the healing rate in no option critical limb ischemia. This is a patient with a large wound infected and with osteomyelitis in the hindfoot. We treat it with the open partial calcanectomy, and we use dermal substitute, negative pressure wound therapy, and lipogems, and we were able to obtain the complete closure of the surgical site. Another patient with an osteomyelitis, kidney disease patient with an exposed bone in the first metatarsal, and we were able to obtain the complete healing after 3 months. And the third patient, another kidney disease patient with osteomyelitis in the forefoot, and we were able to spare also the first toe. So in conclusion, CLI no option is one of the most important factors for limb loss, especially if associated with the progression of infection. If vascular impairment is stable without rest pain and with minor and stable soft tissues involvement, conservative treatment should be considered possible. Novel surgical approach with delicate debridement, localized sequestrectomy, and coverage with dermal substitute should be planned. Peripheral blood, mononuclear cells, transvertebral transport, microsoft fat may be useful in reducing risk of amputation, but obviously we need a randomized control trial for evaluating this novel surgical approach. Thank you very much for your attention.
Thank you for the nice presentation, Dr. Luca. And please let me welcome Dr. Hani Tayed from the UK to talk about managing